Welcome to Dr. Balaga's God Knowledge Doc podcast, your quick dive into the latest medical breakthroughs to keep you ahead of the curve. Let's get started. Today is July 3rd, 2025. This video is a review published in JAMA online on June 30th, 2025 on osteoporosis, epidemiology and risk factors. 1 in 3 women and 1 in 5 men above the age of 50 years of age will experience osteoporotic fractures. Hip fractures, 24% 1-year mortality and reduced mobility. Key factors: age, female gender, low body mass index less than 20, prior fracture or fall, parental hip fracture, glucocorticoids, tobacco, alcohol, chronic liver, kidney and inflammatory disease, peak bone mass determined by genes, hormones, estrogen, testosterone, nutrition, and physical activity. Most fractures occur in patients without T less than or equal to minus 2.5. So the importance of clinical tools like FRAX. Bone mineral density via DXA is the gold standard. WHO classification: normal is when the T is equal to or less than minus 1. Osteopenia, minus 1 to minus 2.5. And osteoporosis, equal to or less than minus 2.5. Vertebral fractures may be silent. DXA-based vertebral assessment or radiography is recommended. Use the FRAX tool for 10-year fracture risk. It includes age, body mass index, smoking, alcohol, parental fracture, rheumatoid arthritis, and use of glucocorticoids. Trabecular bone score (TBS) adds structural risk detailed to bone mineral density. Screening: women above the age of 65, men above the age of 70 or younger with risk factors. Limited data support routine screening in men. Therapeutic options: lifestyle, calcium 1000 to 1200 milligrams per day, vitamin D 600 to 800 international units per day, exercise, resistance exercise and balance, and fall prevention. Medications: antiresorptives like bisphosphonates, alendronate, risedronate, zoledronate, decrease vertebral and hip fractures. Denosumab decreases vertebral, hip, and must be followed by bisphosphonate to avoid rebound fractures. Anabolic agents used are teriparatide, abaloparatide, romosozumab for very high risk patients and must be followed by antiresorptives. Romosozumab carries cardiovascular warning. Monitoring sequence and services: repeat bone mineral density 2 to 3 years after the initiation of therapy to track response. Drug holidays: consider after 3 years IV or 5 years oral bisphosphonate if moderate risk. If stopping denosumab, transition to bisphosphonate critical to avoid rapid bone loss. Anabolic drugs: antiresorptive sequence better than reverse. Fracture Liaison Services improve treatment rates 38% versus 17% and reduce refracture. It's important to have shared decision making and integration of electronic medical record to improve adherence and outcomes. If you enjoyed this episode, share it with your colleagues. When we change how we see disease, we change how we shape lives. Until next time, stay curious, stay compassionate, and keep seeking wisdom. Podcast brought to you by Master MedFacts at mastermedfacts.com.